Good morning. I'm Wayne Koch, and as President-elect of the American Head and Neck Society, it's my privilege to introduce the speaker for the presidential address, Greg Wolf. I first heard the name Greg Wolf as a chief resident in my fourth year at Boston at the VA hospital in the midst of that first thrill of learning how to do major head and neck surgery. And I must say that I was curious, or perhaps the word is mystified, about who this young head and neck surgeon was that was cooperating with Ki Hong, who was at the VA then, to do something other than a laryngectomy for people with larynx cancer. Needless to say, this was an iconoclastic time that we were in a city where C.C. Wong was across town, and those of you who don't know, C.C. stood for Can Cure, and the surgeons bristled a bit around that. But Greg saw before most of us, at least before me, that the way forward for our patients was a way of cooperation. Next time I heard Greg's name was a year later when I decided that I would try to pursue a career as a clinician scientist. At that time, I looked around the country to see who out there was actually doing surgery a couple of days a week and actually in the lab a couple of days a week. And now you might be able to name a number of people, but back then I could only find three. One of them was Greg. So I made some calls. You didn't do emails then. Made some calls and got some interviews set up and came out to Michigan. And Tom Carey, to this day, wonders about the mistake I made in not going to Michigan. Be that as it may, I certainly missed an opportunity to learn with some of the masters in clinician translational science, and Greg is certainly one of those. He's had an illustrious career. His 1991 first author New England Journal paper, just one of almost 200 peer-reviewed papers, that shut my mouth. If you're the leader of a cooperative group, you can get published as a first author in the New England Journal. Quite an accomplishment. But then from there, a leader in cooperative group trials through SWOG and others, a leader at the CTEP and now at the steering committees, the longtime chairman of one of our flagship head and neck otolaryngology residencies, and the leader of one of the spores in head and neck research, just to name a few things. I watched with admiration Greg at the council meeting this year. He's rarely, unlike myself, the first person to blurt out an opinion about something, but often the last person to say something about an issue. And that's because he's listened to everybody and found consensus and mixed it in with his own wisdom and then put forth a place to go, a position that makes sense to everyone. And that kind of leadership has helped us as a society this year as we think about how to partner with the ASTRO and ASCO in education about head and neck surgery, as we consider how to incorporate into our society and into our fellowship of people in multidisciplinary care of head and neck, folks such as oral surgeons and others that have a place that we should respect and incorporate. So without further introduction, we have a plaque for Greg. I'll read you what it says as he comes up to receive this. It says, Gregory T. Wolf, for his role as the American Head and Neck Society President of this year, in grateful recognition for your years of leadership and service to the American Head and Neck Society and the specialty of head and neck oncology, your vision for multidisciplinary care and translational research has played a central and innovative role in the improvement of care of our patients. Greg?
Thank you, Wayne, and I'd like to thank my mom for helping him with that introduction. A lot of people have stood here before me to give presidential addresses, and so I'm a little nervous, and I'm going to try to get through this, but I welcome you here this morning, and I'm glad to see a lot of you and my friends in the audience, members of the society, conference participants, and guests. This is, one of the greatest honors, a clinician can have, is to be recognized by his peers, and this is indeed a privilege for me to be here and a good fortune for me to enjoy this moment and try to share with you my perspective of where I think head and neck surgical oncology has to go in the next decade. And so I've entitled this Tradition, Teamwork, Tailored Treatment, Surgical Oncology in the Genomic Era, because this really represents the evolution of treatment progress in cancer therapy, and not only talks to our traditions but points a little bit to the future. But that future, if I can find that future really stands on the shoulders of surgical giants, and we have a proud heritage of leaders in our specialty who actually formulated theories of clinical oncology for us using the best information they had available at the time. And indeed, these folks were innovators. They organized ancillary care, and even in the early development of surgical oncology, embraced multidisciplinary treatment. And so I'd like to paint a picture of how we prepare for the future. And this is a future that I believe begins with the vision that our future treatment strategies in surgical oncology will have to incorporate personalized approaches that are based on predictive markers. And that as we talk about how to integrate surgery into future treatment paradigms, we're going to have to talk about how we tailor treatment to individualized patients and to individual tumors, how we will target not only the tumor but perhaps cell populations within the tumor, and how this new approach is really going to require a new team of ancillary scientists to help the surgeons in figuring this all out. And so I put these words up from Robert Frost that two roads diverged in a wood, and I took the one less traveled by, and that's made all the difference. And if we look at the less traveled road, I think this has some special meaning for us because there are two paths. We've followed a path of advances and really remarkable advances in surgical technology, but we're being asked to now travel yet another road that is perhaps a little less worn, a little less secure for us as surgeons. And I think it's important for us to figure out how we can do this, how we can incorporate really remarkable progress in free tissue transfer, robotics, minimally accessed surgery, application of new technology, laser, and others, and incorporate in that schema biooncology, tissue engineering, all of the things that the genomic era is going to bring to us in terms of molecular risk profiles, tailoring treatment, gene and molecular therapy. And so as a specialty, we have to figure out how we're going to follow these paths, and will these paths ever really cross and merge in the future? And how can surgeons in training follow more than one of these paths? And are there special requirements that are going to be necessary for us to sustain surgical oncology in these changing times? And how do we best execute and fill our responsibilities to our patients? So I'd like to pose this hypothesis for us this morning, and that is that the future success and growth of head and neck surgical oncology and really achieving maximum benefit for our patients is going to require following that road less traveled. And to support this hypothesis, I'm going to offer three ongoing paradigms or shifts in paradigm, changing paradigms that I believe will hopefully convince you that this is the path we have to follow, and that these changes in paradigm really demand new approaches to surgical training. And lastly, I'll leave you with what I hope are some practical recommendations for where we, both as individual surgeons and we as a society of surgeons, need to go in the future. So the first changing paradigm, and Wayne actually alluded to it, was really the acceptance by surgeons that alternatives to radical surgery that were based on concerns for patient morbidity and quality of life are acceptable. And of course, this isn't a new concept, because as surgeons, we've always weighed the morbidity and the side effects of what we offer patients against the benefit. But it wasn't until we started integrating chemotherapy and radiation as an alternative to radical surgery that this became a really important paradigm shift for surgical oncologists. And so this story began, as Wayne has indicated, really in the early 70s, as we began to introduce neoadjuvant chemotherapy into treatment regimens, and we started seeing in previously untreated patients with advanced laryngeal cancer that you could give these patients several cycles of chemotherapy, multi-drug therapy, and you would see complete disappearance of the tumor. And this really prompted thoughtful surgeons and thoughtful oncologists like Ki Hong to ask whether this achievement of high rates of complete tumor regression could somehow be integrated into our treatment regimen, because traditionally achieving high rates of complete tumor disappearance with chemotherapy has been a hallmark of progress in the solid malignancy of any disease. But it was really left to surgeons to try to figure out how to integrate neoadjuvant chemotherapy into a treatment regimen that would decrease morbidity, and could you avoid the morbidity of a radical resection by integrating this powerful new modality. And so really starting in the early 70s and then culminating with Ki Hong's conception and our completion of the VA larynx trial in really 1991, we tried to ask that question. As those of you who are familiar with this trial, this was really the first time that we compared head-to-head a surgical procedure, total laryngectomy, with a different approach in which patients were treated with a chemotherapy initially, and based on the biologic response to the drugs, went to either radiation therapy as a way to try to avoid surgery, or if they didn't respond, those patients went to surgery. And so this was really the first test of a biologic concept of treatment that might help avoid morbidity. And unfortunately, this was a negative trial. It obviously got some press, but in fact, if you look at the survival rates with these two treatment approaches, they were not significantly different. In fact, the surgery arm does a little bit better than the patients who are randomized to initial chemotherapy, but these differences are not statistically significant. And so in terms of our improving survival rates, this was not a success. In terms of a secondary objective, which was avoiding laryngectomy, this was a success, because fully 2/3 of these patients on the chemotherapy arm were able to preserve a reasonably good functioning larynx. And of course, the next step was confirming these results, and this was done by the EORTC in Europe in hypopharynx and epilaryngeal cancers with almost the same design as the VA study. And again, unfortunately, the same results. And if we look at long-term survival rates, you can see survival rates are not good. And at 5 years, there's really no difference between the treatment arms, even though early on it looked provocative that perhaps the group receiving chemotherapy who failed and went to surgery were doing a little bit better. If you look at 5 years, there's no difference. And again, almost half of these patients were able to avoid laryngectomy. And then, of course, the next major advance was the intergroup study, which was headed by Helmuth Gepfert and Arlene Forestier. And this was a 3-arm study which looked at whether radiation alone, concurrent chemotherapy and radiation, or an induction regimen, which was very similar to the VA schema, was better in terms of larynx preservation. And this had a clear winner in that the concurrent chemotherapy and radiation, if you looked at larynx preservation as the outcome, this was the clear winner in this case. But again, unfortunately, in terms of making an impact on survival, this was a negative trial. And if we look at long-term differences in outcome by those 3 treatment arms, there's no significant difference in terms of survival. So once again, a success in terms of avoiding radical mutilating surgery, but no real improvement in terms of fairly, if you look here at 5 years, 50% survival rates, not very good for advanced laryngeal cancer. And this was puzzling to a certain degree, because at this point in time, there'd been a tremendous amount of of research and clinical trials incorporating chemotherapy, and consistently it looked like combining chemotherapy with radiation was always better than radiation alone. And so it's a little puzzling that, in this trial we didn't find that true. And the data for this really came from the first meta-analysis of combining chemotherapy with local therapy, and it was recently updated. And it is a consistent finding. And here in almost 10,000 patients, a 6% improvement in overall survival when you add chemotherapy along with radiation, compared primarily to radiation therapy alone. And so how to incorporate all this information and what are the implications for us as surgical oncologists is one of the challenges we have to face. And I've listed some of the implications here, and this, everyone in this room knows, is that as a result of these studies, the organ preservation approach for laryngeal cancer has been widely adopted, and there is pretty consistent evidence that the concurrent administration of chemotherapy and radiation seems better than radiation therapy alone. But of course, this adds significant toxicity, and so how to go forward and what's the best treatment is still really not clear, because when survival differences are minimal, and you have to start looking at trade-offs in terms of morbidity and toxicity, it becomes somewhat confusing in terms of how to educate your patient as to what the best treatment approach is, and yet we still don't know, I think, what the best organ preservation treatment approach is for patients with advanced laryngeal cancer. And of course, I would remind everyone that none of these approaches has really provided improved survival rates compared to primary surgery alone. It raises the question and leads to the next paradigm that is evolving, and that is if the response to a particular treatment, if you could predict that response, is there a basis for selecting treatment based on the biology of the tumor? And it really brings us to the second change in paradigm that we're experiencing, and that is the potential importance of biology of the tumor as a tumor staging factor and as a predictive factor. And the evidence for this, again, goes back to those early neoadjuvant trials in which we saw patients that got several cycles of chemotherapy, and we watched the tumor melt away, and we're left with a site, whereas if you biopsy this site, you can't find any evidence of histologic tumor. And so it's clear as a result of those experiences that some patients respond and some patients don't respond, but consistently demonstrated those patients that experienced a complete disappearance of tumor, that medical oncologists like to call a complete response, always had a better prognosis. The outcome, no matter how you treated them down the road, they tended to do better than patients that didn't respond. And that biology, that determined treatment response, might be something that you could use to try to determine appropriate treatment selection. And some of this evidence came from the VA study and the head and neck contracts program before that. And if you simply looked at the response to chemotherapy with respect to achieving a complete response, those patients who had a complete disappearance of tumor do better, and if it occurs quickly here after 2 cycles, they do better than patients who take 3 cycles to achieve that complete response, and they do better than patients who never achieve a complete response. And of course, the other consistent finding in those trials of neoadjuvant chemotherapy was the non-responders who aren't on this always seem to do worse, and that's been a consistent finding. When we looked at that in the VA study, we were somewhat surprised because this was the first time that those non-responders, that is, those patients that were taken directly to surgery because the tumor didn't respond, now for the first time did as well in survival rates as the patients who were responding and going on to radiation therapy. And so this for us was a remarkable finding that suggested that perhaps those non-responders, if treated in a different way, could fare better than we typically would expect. Well, these findings have been confirmed by other studies, and this is just one example of, again, advanced laryngeal cancer in which patients who have a failure of a complete response but go on to laryngectomy do remarkably well and do as well as the group down here that gets a complete response and goes on to radiation therapy, with the group that is a non-CR and goes on to radiation therapy not doing quite as well. So we decided at Michigan that it was time to try a proof of principle test to determine if appropriate selection of patients for what we would call targeted chemoradiation could improve overall survival. And so we designed a trial, this trial here, that began with just a single cycle of chemotherapy as a biologic test to see if the patients would respond. And if they responded quickly, we knew that they were likely to go on to a complete response if you gave them several more cycles. And so we made a treatment decision early that those that had a dramatic response after one cycle of platinum and 5-FU went on to then the best treatment at that time, which was concurrent chemotherapy and radiation, platinum, along with conventional radiation. And then those that didn't achieve that quick response went to salvage laryngectomy. The responders were eligible to receive yet some additional maintenance chemotherapy after completion of radiation. This has recently been published, and if we look at just our ability to avoid surgery and larynx preservation, we did very well with 70% of the patients having larynx preservation, and you can see here 23% having early or planned laryngectomy up front, with relatively few, 6%, requiring laryngectomy down the road because of recurrence. But perhaps more gratifying were the survival results. And this was the first time we had seen such high survival rates in advanced laryngeal cancer, with cause-specific survival rates of about 87% in these patients. Fairly advanced disease, a third of these patients with T4 cancers, and the majority of those with gross cartilage destruction because of their cancers. And so, this was provocative to us that maybe this was proof of principle. Unfortunately, this is not a randomized trial, and so we didn't really have anything to compare to except our immediate prior experience, in which we were giving 3 cycles of chemotherapy, concomitant boost, hyperfractionated radiation, and then using surgery as a salvage procedure. And when we compared these results, let me see, can I go back? Yeah, there it is. Yes. Go back one more. Because the other thing that we saw in that approach, again, was that those non-responders, this group, the patients that underwent laryngectomy or planned laryngectomy, the survival rate for this group was excellent and better than we would have expected for non-responders, and as good a survival rate as the larynx preservation group. So how did it compare to our immediate prior experience? Well, we did much better, and if we look at overall or even disease-free or cause-specific survival, it's about a 50% improvement in our success rate with this approach over what we had been doing previously. So what do we learn from this? Well, it's clear that not all patients benefit from the administration of chemotherapy, and this was in both a neoadjuvant and adjuvant setting, and we're not sure exactly why that is. It could be because of delay in onset of surgery or our detection of relapse, toxicities from the concomitant chemotherapy and radiation, growing of resistant cell populations or accelerated repopulation of the tumor. But it's very likely that a lot of this is explained by the molecular biology and the genetics of the tumor. And so we went back and asked Tom Carey and Carol Bradford in the laboratory to begin to look at gene markers to try to develop some surrogates for using chemotherapy as a decision factor. And we began first with looking at p53 expression, because this was the most commonly mutated gene in head and neck cancer. And we simply looked at whether this gene was overexpressed or not. And although in other sites the overexpression of p53 or the mutation of p53 tends to have a poor prognosis, we found in the VA larynx trial, looking at those specimens, that there really wasn't any prognostic importance to p53 expression. However, if we looked at p53 as a predictive factor for our ability to avoid laryngectomy, there were significant differences in that overexpression of p53 was associated with a higher chance of preservation of the larynx, successful treatment with chemotherapy and radiation. We also looked at other factors to see if traditional staging factors might be the real reason why patients responded better to chemotherapy and radiation. You can see there were a number of clinical factors, including tumor site, smaller tumors, tumors with very aggressive growth patterns, smaller tumor size and stage that were associated in some way with better responses, higher rates of larynx preservation. But again, p53 overexpression and high proliferative rates of these tumors were also associated. And so when we entered that in a multivariate analysis, interestingly, the clinical parameters drop out and p53 expression remained highly significant for predicting larynx preservation. Well, we were interested in trying to make this more specific because this wasn't good enough to actually select patients on an individual basis, and we began to look at other genes that regulate apoptosis and the apoptotic response to chemotherapy. Doug Trask looked at the expression of BCL2 and BCLX and BAX in these tumors, and we saw that these blockers of apoptosis were overexpressed in laryngeal cancer, and more commonly BCLX was the protein overexpressed as opposed to BCL2. And when we looked at larynx preservation rates with respect to expression of this gene, those patients that had low levels of BCLX expression tended to have a higher chance of larynx preservation compared to patients who had high expression here, 90% larynx preservation rate versus 60%. Again, not specific enough for us to use as an individual treatment selection. And this is just graphically showing an actuarial survival curve for larynx preservation, if you will, based on expression of this gene marker. But if you start combining markers, and here Carol combined p53 and BCLX, you start to divide patients into risk groups with a high risk group for failure being identified as those patients with low p53 and high BCLX expression here, and most likely wild type p53. Interestingly, the expression of BCLX was not only a predictive marker, but it tended to be a prognostic marker in the laryngeal cancer patients. And this is in our own study, which we designed to test these biomarkers. Low expression of BCLX was associated with 100% disease-free survival and excellent overall survival in those 97 patients that we had entered in that study. We've also confirmed this in oropharyngeal cancer in a similar treatment paradigm in which patients receive induction chemotherapy. There's a treatment decision, there's early surgical salvage for non-responders, and the responders go on to concurrent chemoradiation. And again, we start to see, as we look at multiple markers, p53 and BCLX, that we begin to divide patients into very favorable groups of low p53, low BCLX, and high expression of BCLX, identifying a subset of patients within that group that have a resistant, cisplatin-resistant phenotype and poor outcome. Others have looked at markers of aggressiveness in head and neck cancer and predictive factors for treatment results and prognostic factors for outcome. And this is from Kiang's group at MD Anderson, looking at EGFR receptor expression and survival, disease-free and overall survival. And again, you see tumors that have high expression of this growth factor tend to do poorly in terms of treatment with radiation therapy and survival. This was capitalized by Bonner and Harari in their landmark paper in the New England Journal, in which an inhibitor to EGFR, cetuximab, monoclonal antibody, was added to radiation therapy, and they demonstrated a significant improvement now in terms of overall survival when this specific inhibitor of the EGFR receptor was added to conventional therapy. And so these are provocative, but I think the evolving story with HPV is really the strongest impetus now for us as surgeons to accept this paradigm shift that Molecular staging is here, and it's more clearly demonstrated in the HPV story than perhaps the other evidence of EGFR or P53. There's clearly evidence that the frequency of HPV-positive tumors in the oropharynx seems to be increasing, and that these tumors consist of a subset of patients that have a very favorable prognosis. And the data for this a lot of it comes from Maura Gillison's group at Johns Hopkins, in which looking at HPV status of the oropharyngeal cancers, you see that it's not only a significant prognostic factor, but it's also a predictive factor in terms of response of these cancers in patients to chemotherapy or to concurrent chemo and radiation therapy. And so I think this is pretty clear evidence to us as surgeons that these tumors perhaps consist, in here just looking at overall survival, the HPV positive group as a group that has a very favorable prognosis and warrants consideration for new treatment approaches for the HPV negative group. Others have looked at HPV status and here in the oropharynx with most of these patients receiving radiation therapy, and it confirms again that there's a favorable prognosis with the HPV-16 positive group. And here this group by Weinberger using two markers to try to further discriminate outcome. Here looking at a high P16 and high HPV being the best group, with HPV positive and low P16 being down here in the same area as the HPV negative group. So this favorable prognosis with HPV isn't limited to those patients that are treated with radiation therapy for oropharyngeal cancer. And you can see in the group from Italy, in patients treated with surgery and analyzed with respect to HPV status, here the HPV positive tumors, and whether they did not or did receive adjuvant radiation therapy, having the best overall prognosis compared to HPV negative tumors, again with adjuvant or no adjuvant radiation therapy. So this is a favorable group even for treatment with surgical approaches. And if you start looking at adding markers, and they looked at the addition of P53 mutation, because typically the outcome prognostic effect is worse for mutant tumors. You can divide those HPV positive tumors into those that have wild type P53 and HPV positive having the best prognosis. And then if they have a mutant P53, it really didn't make much difference if they were HPV positive or negative. And so just looking at one marker may not be enough to pick out those patients that might need some new or better approach to therapy. We've looked at this in our own group of patients with oropharyngeal cancer, again treated with induction chemotherapy and a treatment decision for surgery made early on. And these are the long-term outcome results. And looking at disease-free survival, we didn't do quite as well as we did in the larynx, but reasonably good results with 76% disease-free survival at 4 years. In this group of 66 patients, we did look at HPV, and again, easily demonstrated that those positive tumors patients do much better than patients with HPV negative tumors. And if we look at other predictors of both response and prognosis, gender seems to be important, with males doing better than females. Interestingly, smoking status makes a big difference in that current smokers have the worst prognosis, and the prognostic effect of HPV is actually a quantitative one if we look at titers of HPV-16, with the lowest titers having the worst prognosis, and of course the positive tumors being the ones most likely to achieve either a complete or partial response to induction chemotherapy. It was interesting to look at smoking status in this group, and I don't know whether it's because smoking tends to cause P53 mutations, or it's a strong methylation epigenetic factor in leading to methylation of tumor suppressor genes. But if you're HPV positive and you don't smoke, or you quit smoking, your outcome is really pretty good. But if you're HPV positive and should have a good prognosis, but you continue to smoke, your prognosis is just as bad as those patients who are HPV negative. And so maybe there's a role for some behavioral modification. And I think some of the implications from these data are interesting and important because we're beginning to see that some of the subset data could allow for differing therapy for groups of patients who have very identical and very similar clinical tumor characteristics. And as surgeons, we've tended to rely on those to help guide us in deciding a treatment based on how big the tumor is and whether it's spread to metastatic nodes and what it looks like and where it's arising from. But in fact, I think we have to shed that concept and start embracing a molecular concept where tumors that look identical in these patients are going to behave very different, and their treatment might necessarily be very different. And if we use a biologic classification, I think that we could begin to identify those tumors in which a very conservative surgical approach could be very beneficial and function sparing for our patients. And in fact, we should be able to identify those patients with the poorest prognosis that would really benefit from the newest therapies. And of course, as a single institution, nobody has enough patients to do these kind of studies in subsets, and so it really demands that somehow we have to all come together and share our patients in order to answer these types of questions. And then finally, this leads us to the third paradigm that we're experiencing and is evolving now, and that is using molecular markers for risk assessment, for survivorship, and prevention intervention strategies. And I believe these will be based on genetics and molecular biology, and that there's going to be exciting new possibilities, and I think that Ki Hong is going to talk a little bit about that tomorrow as we start to look at cancer as a chronic illness, and we start to look at the role of host factors and host immunity and the tumor microenvironment as things that we actually can modulate in the post-treatment period to try to prevent cancer from growing. And is there evidence for this? Well, there isn't now, but it's beginning, and some of the areas that I think will provide that supporting evidence will relate to head and neck cancer stem cells, to epigenetics, and you'll hear a talk from Richard Shaw at this meeting about that, a better appreciation of the potential role of chronic inflammation in the etiology of these tumors, and then perhaps some insight into things that we can modify in terms of health behaviors. And I'll just give one example of where this might be important, and this work comes from Sonia Duffy's work within our SPORE, in which we've looked at health behaviors, smoking, diet, and we've looked at serum markers of chronic inflammation to try to guide us as to future strategies for prevention. And the preliminary data really comes from an analysis of data from 685 initial patients that were entered into this longitudinal study in which we do detailed health surveys, we do obtain blood and tumor samples, and we do detailed nutrition surveys. And interestingly, as we looked at this and looked first at smoking, smoking is an important prognostic factor. And whether you look at disease-free or overall survival, never smokers always do better. Current smokers do worse. And if you could make an impact on this, we could make perhaps a significant impact in survival. And understanding the biology of this still remains a challenge for us. But as we look at a multivariant analysis and we put smoking into the paradigm, you can see that the risk-hazard ratio for recurrence and death is much higher for smokers compared to non-smokers. And if you look at traditional things such as the site of the tumor, pharynx cancer or larynx cancer, stage of tumor, or if we even look at our own treatment, none of these are as powerful predictors of outcome as the patient's smoking habit. When we looked at diet, it was quite interesting to see that patients who had either high or moderate intake of soy do better than patients that don't eat soy products. And this was strongly linked to both fruit and vegetable intake. And here patients with either high or moderate fruit intake doing much better than patients who had low intake of both fruit and vegetables. And all of these dietary things are interrelated, but even after adjusting for fruit and vegetable intake, in a proportional hazard model, soy intake remained a significant predictor of outcomes. So there may be some dietary manipulations that can be done to improve survival rates for our patients. And again, understanding the biology of that is a challenge for us. And then lastly, when we looked at a whole series of pro-inflammatory cytokines in the peripheral blood of these patients, interestingly, levels of IL-6 were predictive of outcome with patients with the highest levels having the poorest prognosis, and suggesting to us that ongoing chronic inflammation could be important. So I leave you with the thought that these tumors and the patients are biologically heterogeneous, and that the patient is more predictive of response to therapy and our overall outcome than our traditional anatomic staging factors, tumor site or tumor extent, and that if we're going to understand tumor and host biology, I think it's going to lead us to better treatment selection. And once we match proper treatment to the proper biology, we're going to see finally some improvement in overall survival rates for these groups of patients. So we're beginning to talk about a biology-based treatment approach in which we'll look at tumor profiling that reflects things such as tumor aggressiveness, the heterogeneity of the tumor, the genetics of the tumor, metastatic capacity, presence of and numbers of stem cells, and factors in the tumor microenvironment that may be important. And we'll begin to look at patient risk profiles that include looking at their innate immunity, at their host genetics, at the pharmacogenetics that are there that may impact on response to radiation or response to drug. And in all of this work, we're going to be identifying new targets for therapy with both drugs and biologic, including vasculature, looking at ways that we can modify the epigenetic profile of these patients that would affect proliferation and lead to cytostasis rather than cytoproliferation. Out of this work, we will find ways that we can modify toxicity of drugs through looking at the gene pathways that are affected. And I believe you're already seeing how we may start using these biologic pathways to allow dynamic imaging of tumors so that real time during therapy we can actually see whether the tumor is responding or not responding, and we can rapidly change therapy or go in and perform adequate, timely surgery. At Michigan, we've begun developing a tailored treatment matrix where we've looked at response to individual modalities, including biologics, with respect to a whole battery of factors, including immune response and host response, P53, gene expression of genes that relate to apoptosis, growth factors such as VEGF or EGFR, histologic patterns. So as this matrix grows and we look at weighing a tumor's response to individual therapy, we'll start developing sort of precise treatment paradigms for individual patients. And this is going to be a challenge for us as surgeons. And so we're going to be challenged to figure out how to do this and yet maintain our traditional role in providing diagnosis, patient education, monitoring the treatment of our patients, follow-up care, coordination of care, tumor surveillance, the diagnosis of recurrence, and support during both success and failure, and how to incorporate this type of treatment matrix and team science into this traditional role for us is a challenge. It's going to require better basic science education during residency and during fellowships, and it has to allow us to begin to be innovative, surgically innovative, as we look at new fields for surgical oncology, including surgery for isolated metastases, removal of dormant cell populations, image-guided surgery, surgery that might involve biologic gene insertion, monitoring, or implantation of new therapeutic devices. In order to meet this challenge, we're going to have to encourage basic scientists to join our team. We're not a big tumor in terms of numbers, and we really need to reach out to the best basic scientists working in cancer in general and convince them to study our tumors. And this new knowledge that's going to come really will demand accepting a new matrix of care. So I leave you with the idea that yes, we are a team. This multidisciplinary model has to adapt to these rapidly changing scientific advances. We are developing and have to embrace a new dependency on very sophisticated pathology and molecular biological tools. We need to explore new biostatistical methods to try to design and analyze treatment results in smaller groups of patients, because we just can't answer all the questions in studies that have 300, 400, or 500 patients. And we have to look at new endpoints for success of treatment, including biologic endpoints, quality of life endpoints, cost, and prevention type endpoints. In all of this, we can't forget that we need to educate our patient as to where we're going and why we're going there, and encourage their participation in those trials. So how do we better prepare, and who's best prepared to lead this effort? I think that as surgical oncologists, both our tradition, our aptitude, and our training have poised us to accept this role, and we need to embrace it. We need to incorporate these new players in an expanded team during these changing times of shifting paradigm, and that our residents, fellows, and ourselves as mentors must really acquire the prerequisite experience and knowledge in genetics, statistics, informatics, clinical trial methods, and multidisciplinary models of care if we're going to make this happen. So I leave you with these recommendations, both personal recommendations, and I'll talk about our society needs. And these are things that we can do now, and that is identify an interested biologist, or I'll call him a biopathologist, to integrate them into our treatment team in terms of helping us make treatment decisions. We need to integrate biostatisticians in this, because when you start looking at risk profiles and these large matrices, you can't make sense of it on your own, and you really need the help of a biostatistician. We need to continue to provide the necessary surgical and technical excellence that we have in the past in providing comprehensive oncologic care. And we really need to embrace critical review of all of these new concepts as they come out. We need to understand that we have to be responsible for designing and implementing survivorship protocols and measures of quality of life if we start using these as endpoints, and that we need to participate as a team in collaborative clinical trials. So we began with two roads that diverged in the wood, and the hypothesis that we need to take the one less traveled, but also the question of, do these paths ever come back or merge in the future? And I think the answer is clearly to all of us, yes, that eventually there only will be one path for us to follow. And that as a society, our challenges are really three: that we need to promote the development of leadership and innovation and critical evaluation of these evolving treatment paradigms, and it's up to us to do it. We need to recognize our responsibility to define the role of surgical care within these evolving paradigms, and we need to expand the role of the Head and Neck Society in training and education, including developing and participating in forums for guideline development, participating in the task forces of the National Cancer Institute Steering Committee, the National Cancer Center Network, and participating along with our other oncologic societies in education for head and neck oncology. So this is the old team, and this is the new team, and we really need functional imaging, cell biology, epidemiology, the biostatistician, the geneticist, a clinical trialist, probably an information technologist, in order to sort this out and design the future treatment strategies that are going to help our patients. At Michigan, I've been very fortunate in surrounding myself with an outstanding team listed here, and the work that I've presented is really their work. I merely encourage them and prompt them, and I couldn't be successful in what I've done without this supporting cast. And of course, this is the work team, and I would be remiss if I didn't mention that I couldn't be successful if I didn't have a wonderful home team. And these are my children, Melissa, Jennifer, my wife Suzanne, my son Michael, and the newest addition, my daughter-in-law Amanda, and Jillian Grace, who was born in February as our first grandchild. So I thank you very much for the privilege of talking this morning and sharing these with you. Thank you.